very unique session called as Science and Fun in Ophthalmology.
A session that promises to be educating, entertaining, exciting, all in equal measure. So this is going to be a combination of fun, luck, and knowledge. I'm Dr. Tinku Bali, and I welcome you this afternoon to the show. Welcome to all the teams and to the participants and the audience and our esteemed judges.
So I hope this is going to be a very exciting, entertaining, and fun session for you all. So here, along with the science, the luck is also going to play a major role in deciding who wins this.
So before we begin, I'd like to call on stage Dr. Harbans Lal, who has been the mastermind of this show. So give him a big round of applause. Welcome, sir.
Good afternoon, friends. As we know that to be successful in the life, you need to have a certain skill sets. That means you got to be surgically good. Your medical examination and treatment should be perfect. You should have a good knowledge, and you should have a good personality to succeed. So we are going to test all of it, but at the same time, by doing the surgical round, medical round, quiz round, and a lifestyle question. But at the same time, all of them with the same skill set don't succeed as much as the others. So luck plays a very important part in your life. So after your presentation, there will be game of a snake and ladder and see how lucky you are today. So with this, game is going to test the participants' luck as well as their knowledge. At the same time, we are going to see how lucky our audiences are. And that was the idea I gave to Dr. Lalit Verma. Dr. Lalit, he is the man who ultimately, all of you know Dr. Lalit Verma, he needs no introduction. He gave life to this concept. So we got this special software developed, which was done by Kunal from Easy Solution. And after all the team first will go for a surgical round. After judges have given the marks, then they will roll the dice on the stage to see where they reach. And each round, they will get the judges have got the placard over here, which they'll be showing how much marks they have got. So, Dr. Lalit, so I invite Dr. Lalit Verma on this stage.
Big hand, please. Welcome, sir.
Thank you, Harbans. You see, this is an innovative concept. It's an innovative concept where, as Harbans said, that apart from knowledge, you need to have some luck in life. Otherwise, you may fail in this thing. And we have 4 teams, competing teams. They have been divided red, green, and blue, yellow. So, and each one of them has 1 captain and 3 participants. So, believe me, this there are. I think Tinku, you will tell about the rules of the game and next step.
Nikita, please tell the rules of the game.
Right, so we have 4 rounds and we'll go round wise. So we'll start with the first round, which is a surgical video round. Each team will choose 1 candidate who will present a video for a period of 3 minutes. And they will first be marked by our esteemed panel of judges. Then after that, there'll be a roll of dice to decide who scores in the luck part, and then we will add these 2 scores and have the final winner for each round. So the second round is the medical round, where all of the team members are going to present 1 medical case, which was a diagnostic or a management dilemma, again for a time period of 3 minutes. And then the next round is a rapid fire quiz round, where each team member will be given 2 minutes to answer a maximum of 10 questions. And the last round is a lifestyle round, where our judges are going to ask a question not related necessarily to ophthalmology, and the person has to answer in 1 minute. So after each of these rounds, we are going to have a roll of dice, and eventually we are going to decide who wins overall with respect to science and luck both. So those were all the rules of how this game is going to go ahead. And Dr. Tinku, can we have a little bit about our judges? Can you please call our esteemed judges on the dais, please?
First, I'd like to tell the audience what's in store for them. So this promises to be This promises to be exciting for the players, but it's equally exciting for the audience. You all have been given t-shirts with numbers on it, and we have the very same numbers with us in a box. So after every round, there's going to be a draw of lots, and the lucky person could be you. There are going to be very exciting prizes, mega prizes actually, after every round. And at the end of the third round, we again have two to three very big prizes. Super mega prizes. So hold tight.
Tinku, you're absolutely right. You see, audience is not left alone. Audience is not a mute spectator to what all these blue, green t-shirts are presenting here. Believe me, they have enough of... Cash. Yeah, this is loaded, I'm telling you. I wish, Tinku, I could have been there, because this is hard cash. Hard cash. And abhi nahi. Wait. All of you have t-shirts, and people who are wearing t-shirts, they only get it. Haath mein nahi pakad sakte t-shirt ko.
Yeah.
You have to wear that t-shirt. And on that t-shirt, there's a number. And if you are lucky, wo number aa gaya, so he is going to give you 5,000 rupees cash. First two rounds, 5, then 7.5. The reason we want you to stay till the end is because last is more than 10 also. So imagine one person getting 20,000 rupees in 1 hour time. Itna to doctor ko nahi milta hai. In 1 hour.
You can call up your friends and tell them about this quickly. Yeah. So,
And what about team prizes?
Yeah.
Did you tell about team
yeah,
prizes?
we've already told about the team.
80, 60, 40, 20.
86. Okay, this is the
Science
first.
Science and luck first. Plus
Okay.
So there are prizes for the team also. So the first prize is 80,000 rupees for the team which wins the science and fun both. That means overall lucky as well as. And second prize is 60,000 for the one who is with the science. Then third for the runner-up of the SFO, and fourth prize is for the runner-up of the science. So, but no team will get the two prizes. So each team will get some or the other prize, starting from 80,000, 80, 60, 40, 20. जजेस को कब बुलाना है? तुम्हारा फ्लो क्या मुझे नहीं पता है। ठीक है, कराओ। हाँ, चलो करा दो टीम।
Team intro. Pehले team. We'll call all the teams up, please. Team Red. Team Red, stand up and wave. Yes. So Dr. Carmen Chan, who's the captain. Yes. Dr. Ellie Pradhan, she'll be here soon. Dr. Rolika Bansal, come on, give them a big hand. Dr. Ragini Hasmukh Roy. Team Yellow, Dr. Praful, who's heading the team. Dr. Pranita, Dr. Rahul Mayer, Dr. Asif. So Dr. Bhuvan is there instead of Dr. Rahul. Bhuvan Chanana.
Take it, next program.
All right, then we have the blue team. Dr. Srinivas Joshi, the captain. Big round of applause, please. And then we have Dr. Prasanna with us. Dr. Deepak. Dr. Kaushik has stepped in for Dr. Deepak. Please wave. And then we have Team Green. So Dr. Avninder stepped in, and Dr. Avninder will be presenting a surgical video. Then we have Dr. Shweta Walia and Dr. John Sarkar and Dr. Annu Malik. A big round of applause for all the teams. Are you ready?
Are you ready?
Judges का? Judges दो ही है क्या?
जाएगी तो सिर्फ तारीख और यही होता रहा है मिलाद तारीख पर तारीख तारीख पर तारीख तारीख पर तारीख तारीख पर तारीख मिलती रही है लेकिन इंसाफ नहीं मिला मिलाद इंसाफ नहीं मिला मिली है तो सिर्फ ये तारीख
आप लोग भी लाओ।
You see, unlike whatever judiciary you see in high courts and session courts and supreme courts, तारीख पे तारीख यहाँ तारीख नहीं है. यहाँ judgment our honored judges will give today only and now only within this hour. So we'll have Nitin Verma from Australia. So for joining us, and you can trust him. You can trust him. He will do justice. And we have Tariq Ali Raza.
If you want to bribe him, the time is now.
Tariq, can you join from Bangladesh?
इसको बुला।
He will also do judgment to the best of his ability. Without any bribes, you have to tell them.
Yeah, no bribes, but yes, you can try to give bribes if you wish.
I'll invite Dr. Ashish Sagar to come on this stage.
Please join us. Dr. Lalita, somebody, yeah, please join, please join. So we have 4 judges, 4 teams. The judges will give marks, which will be, then snake and ladder game. And then each of the judges will also ask some lifestyle questions. Something like work-life balance or how do you, yeah, please. Other thing which Harbans has done is that maximum marks are 10 out of 10, and the minimum marks are at least 50%. Nobody wants to fail. So all of you should yearn to get 10 out of 10. That all depends on your video quality, medical case, and quiz also. So, shall we? So I'll request all the judges to wear their hats so that they look like judges.
With the dress comes the responsibility.
So all the best to the teams. We'll be starting with the surgical round, so hope you all are ready with your videos.
So the team red, have you loaded your surgical video? So let's start with the team red. And we need to put on the timer. It should be at 3 minutes. No overshooting of the, either way, where you can come either side. कोई particular side है? So the red team is on the other side, yellow team surgical video presenter should be here. Start the video, please.
Okay, so hello everyone, and we are here for the Science Fun in Ophthalmology. And I will be presenting to you a case of a luminous chaos with a little blend of science. So this is a girl who presented to us with a swelling on the left lateral orbit. And as you can see, it's a pretty evident swelling, and there is no ocular movement disability. There is a swelling which is cystic in nature, as you can see, very thin walled. So what did we do? We have to put the element of science and fun. We went for a surgical excision. So the lesion was marked, and decent, slow, meticulous excision was performed. You have to understand that these lesions can be extremely difficult to treat, so you have to go thin, layer by layer, and that's the fun. And I'm telling you, in this ophthalmology part, you have to put science, fun, and ophthalmology together. So we go all around the lesion in slow dissection, as we have seen the preorbicularis layers being excised, and you have to make sure that the lesion doesn't burst. As you saw, that the lesion was cystic, which means it is thin and it can burst anytime. You don't want that kind of fun in your case, right? So what we do is slow meticulous excision, and as you can see, the adhesions are being taken care of. This does not look like a malignant lesion. That's again a fun part, right? Because we're looking at a benign lesion. You want to safely take it out, make the patient happy. We want to be happy, absolutely. And as you can see over here, the slight illumination that you can see, does that look like fun at all? Well, to a surgeon's delight, that is fun, because these kind of lesions are called orbital dermoids, and you don't want to pop them out. You don't want the fun of bursting them, because that's not a surgical fun at all. So therefore, a complete excision was performed, slow dissection around the lesion, and slowly you were about to see the bigger fun in the same, in the lesion excision. And what do? You take a transillumination, and here the fun begins. You see how thin this is, how cystic this is. This could have burst any time. I have a better resolution for the same. It is coming up soon. And then you will see that the lesion lights up. Even the tiny vessels in the lesion can be evidently seen. Look at those tiny lesions. It won't be fun at all if this bursts. So keeping the science and the fun and ophthalmology part intact, we took the lesion out and sent it for histopathology. And when the lesion was sent as histopathology, to confirm, we have to, by the way, we have to make sure that the aesthetic part is taken care of. So you provide internal sutures and external sutures. You want it to be perfect. And histopathology showed and confirmed that it's a benign orbital dermoid. Excellent results. So science intact, fun intact, and ophthalmology taken care of. So this is what I wanted to present it to you all from our side, from Team Red. Thank you very much.
This is only produced by you or surgery done by you?
Sorry, sir?
Surgery done by you?
Surgery
Or?
courtesy is not me, sir. It's Dr. Honavar courtesy.
Okay, okay.
Thank you.
So excellent result. What is the ultimate, takeaway from this?
So the takeaway message is that these lesions are very thin-walled. Very often they burst, and when they burst, they cause post-operative inflammation.
So you have to
We
be careful it does not
avoid
burst.
them. Yes. So it's very easy to burst these thin-walled ones. The entire point is to go meticulously around it, slowly take your time, enjoy the process. The surgery was nearly 2
Enjoyment
hours.
to kahin hoga, burst enjoyment kahan se hoga? Where is the enjoyment if you are so tense while doing surgery? So judges, how do you react to this? Marks by judges. 7, 8, Tariq, 8.
So we'll take it 8,
Your,
2, 8, 2,
8,
7.
8, 8, 8.
8, we take it 8.
So,
Thank you.
8 marks, Hollywood you have got? No, you can't go. Abhi.
We
Because
want to roll the dice.
you have to roll the die, he will roll it.
4, sir.
8 and 4, 13.
4. 12.
So she has got 4 rolling the dice, she has reached at 12. Okay, now the yellow team presents its circular.
So very nice, कम से कम एक नहीं आया, 4 आ गया लग में. There are people, okay, you can
Thank you.
sit back. After red team, we'll have yellow team surgical.
The yellow is here already. And the blue should come on that side.
Good afternoon all. So I'll be presenting the case of a sweet boy, Navneet, a 30-year Down's baby. He had the tendency of repeated ocular trauma, self-inflicted. You can see the periorbital fat atrophy lid scar. Because of that, he developed keratoconus, then hydrops, and complicated cataract. So it was a case of healed hydrops with scar, with keratoconus, with cataract. The option was clear. If it would have been a clear cause of keratoconus, go for a PK triple procedure. But PK leads to poor tectonic strength, and the patient had tendency to self-inflicted trauma. So what I did, I went for a DALK triple procedure. So initially the cornea was scanned using my MIOCT, center of the cornea marked. I screened the peripheral retinal cornea, then did manual trepanation. If you notice, I applied pressure only in those areas where the corneal thickness is good. Then this is a centrifugal dissection of lamellar dissection in the periphery using a blunt hook and Suana scissor. And this is the centripetal dissection using a lamellar dissector. You have to be extremely careful because when you are doing lamellar dissection in scarred cornea, there is high risk of perforation. I was not happy with the residual thickness, so I went ahead and took risk and removed 2 more layers. Now I was happy with my stromal bed, then I went for the cataract surgery. Initially, capsule was stained. An attempt was made to lift the capsular flap, but it was not possible. So I went in with MBR knife and create a nick at the junction of fibrous and non-fibrous capsule. Then using a combination of intravitreal seizure and forceps, I completed the capsulotomy part. And after that, it was a cataract that need to be removed. So initially I thought it's a soft cataract, so I went in with coaxial probe, but it was a hard calcified cataract. So as you can see here, an attempt was made to limited hydrodissection with utmost care to avoid any extension of the rhexis posteriorly. IA was tried, but it was not possible. So a phacoemulsification probe was used. The pieces were emulsified using the probe, and the second instrument was used to bring all this calcified plaque to the center. Then, once the cataract surgery was done, a 3-piece lens was put because I was not sure about the rhexis status. Once the 3-piece lens was put, next task was to replace the removed host cornea with donor cornea, which is not a difficult job for a corneal surgeon. So we took a 8 mm graft, removed the donor adjustment, and applied 16 suture. Next post-op day, graft was well attached and sutures were buried, AC was well formed. This is the AIOS20 picture. However, the doubt was what visual acuity the patient gained, but the patient was mentally challenged. So I'll conclude my presentation here with the statement, probably the most soothing for a surgeon's ear. When I asked the mother, how is the kid doing? She said he could see my face. With this, I could conclude here. Thank you so much.
Thank you, wonderful surgery, Pavla. Now let's see how the judges marks them. 8, 9, 9. So the average is 9.
Thank you, judges.
And roll the dice. 6. So looks like a lucky now.
सर्जरी तो इतना अच्छा मुझे लगा नहीं 6 नंबर और मिल गए.
So now the yeah.
Oh no.
One more.
2. 8, 9 goes to the 17. He was lucky that if it was 16, he would have come down to the 7.
Thank you, whoever rolled the dice.
Why didn't you do PK? सिर्फ लेमिनर क्यों किया? PK नहीं करना था. उसमें scar तो अभी भी पड़ा हुआ ना.
This is a very important point. So the patient had a tendency of self-inflicted trauma. If PK patient land up in self-inflicted trauma, the graft may dehisce. If there is a graft dehiscence, then the entire eyeball is exposed. There will be end off. There will be lens will extrude. So that will be disaster for the patient. So the idea was to do a DAL, give some little bit clear cornea which was there superiorly, and put an IOL. Because the patient was not compliant to glasses, not compliant to contact lenses. So considering all this situation, we went ahead with DLK.
If the patient was not mentally challenged, would you have done PK?
Yes, if it would have been a not mentally challenged patient, I would have sure go for the PKP.
Yeah. So that is the point I wanted to bring out, because it's a learning
Yes,
exercise
sir.
also.
Yes, sir.
So, thank you.
Thank you, sir.
So the next green team should be here, ready with this video. Srinivas
Yes,
should have been ready
Srinivas.
before. Yeah, I already told that the next team should be ready on the other's podium.
Yes, Srinivas.
Thank you.
Already there.
Good afternoon, everyone. Good afternoon, judges. So I'll be presenting a case of a 75-year-old man, one-eyed patient. Sound, please. So he underwent vitrectomy, membrane surgery, and ILM peeling for PDR surgery. Everything went well. It was not a very difficult case where membranes were peeled. But after 8 to 9 months, he developed diminution of vision. Then he developed again 4 to 5 months later because of the lockdown during the pandemic. And this was his fate. The one-eyed patient. The minimum linear diameter was 700 and the basal diameter was 1200 microns. So what I did here was to first remove this reproliferation. This was the culprit for causing the MAC hole, secondary MAC hole. So when I tried peeling this, it picked. The vessel was picked and then slowly it started bleeding. But since it was very near to the fovea, I did not cauterize it. I raised the infusion pressure. And then put a PFO to stop the bleeding as much as possible. The only way left for me to solve this case was to do a neurosensory retinal graft. So here I am using a 41 gauge needle, try to lift the retina a little bit, and then unimanually, can be done bimanually also, but unimanually I was more comfortable. And then you can then take up the bimanual, slowly take a small graft and cut it inside the cauterized marks and slide it under the PFO.
So here the villain, a lot of bullets were coming in. Similarly, the blood was also, it started slightly increasing, and then I had to relieve it from the blood clot and finally place it. I did not disturb the blood clot because blood clot is also used as one of the therapy for closing the macular hole. So this was a double cure, God gifted. Both the things came together for him. And vision improved from 660 to 6.9. 70-year-old one-eyed patient. He was really happy that he could make his own movements. He could make his own diary. He was very, very happy.
How's the Josh? How's the Josh?
Thank you very much.
Now judges turns to give the marks.
Excellent, excellent surgery.
So it's a 10 out of 10.
9.
9, 10. So we'll take it as 10.
Srinivas, already won. 10. Luck dekhna.
Now let's see part of the luck.
5.
5.
Still lucky. If it
Still
was
lucky.
16, you would have gone.
Excellent, excellent surgery.
So now the last team is going to present this surgical video. Dr. Amninder Gupta.
Thank you. You must have seen a cataract Niagara or a black cataract, but here I am going to show you a black vitreous hemorrhage which nobody would have seen here. You can see the hemorrhage is so dark that it's very difficult to delineate where is the retrolental vitreous. So in process of removing this retrolental vitreous, what I do is I also cut the posterior capsule, and the cut is somewhere around 6 to 7 millimeters. I go inside, the view becomes extremely hazy, I can't remove the membranes, so I call my cataract surgeon. Surgeon is daring surgeon like Dr. Harbans Lal, and I said ki yes, you go ahead and make an rhexis and you have to finish the case without the nucleus falling into the vitreous. So cataract surgeon went ahead, did a nice rhexis, and you can see a large posterior capsular tear 7 millimeters. People are afraid 2 millimeter posterior polar cataract, pre-existing rent, posterior pole will give up, but not in my case. He goes ahead, does a direct chop and removes the nucleus, and you can see almost 5 to 6 millimeter posterior capsular rent in this patient. Since there is no vitreous, so aspiration was also done, and bag we cannot delineate, so we go ahead and put in 3-piece intraocular lens inside the eye. Once the media is cleared, the posterior capsule is extended so that I get a nice visualization. I go ahead and complete my vitreous surgery. You can see there is a proliferation extending from the disc to the inferior arcade with vitreous hemorrhage. And what is this? What is this? This black thing, it's almost looking like an bee nest over the retina. And actually, this is a dark colored vitreous hemorrhage. And because it's so dark, it is adherent to the retina. And we peel this membrane. There is an attachment here. There is a gentle peel is done in and towards the retina so that I don't create a rip in the retina, and you can see the whole of the membrane comes out from the disc. This membrane is taken care by a vitrector. There is a residual bleeding on the disc which is cleared. The macula is good. Post did a air exchange, injected anti-VEGF, patient improved to 618 vision post-operatively. ये
इसका तो कोई अंत नहीं। हम दोनों को तो सिर्फ इतना समझना चाहिए कि चमन में इख्तलाते रंगो बू से बात बनती है। हम ही हम है तो क्या हम है, तुम ही तुम हो तो क्या तुम हो।
वाह वाह मेजर साहब, हम ही हम हैं तो क्या हम हैं, तुम ही तुम हो तो क्या तुम हो।
So both cataract and retina surgeon has to come together to give results. Thank you very much.
Thank you, Ananda, for a wonderful video. Now, it's the judges' turns to mark them. And I'll request the audience to please check your T-shirt number. We are going to call by number.
सब कुछ तुम ही तुम हो भाई, सब कुछ तुम ही तुम हो गए। सब कुछ तुम ही तुम हो। 8, 8.
8, 8, 9, 8, 8. Average is 8. Now the turn of the dice. Oops.
कोई बात नहीं. So now comes the most exciting part. We will do audience Sabina, surgical part. You see, all the people who are wearing white T-shirt, not carrying white T-shirt, people who are wearing white T-shirt are eligible for this. So I'll ask Tariq Kali to take out one slip from here.
And meanwhile, the next
Please wear
team
white
red
T-shirt.
to get ready for some medical case presentation. Next video.
Yeah, read out.
Team red, yeah.
This number is 141. Anybody having 141
I
T-shirt?
already told you that keep your number.
141. Madam, पहन के आना नहीं तो yeah, Harbans will not give you the prize. ये पहनना है ना? You have to wear it. Otherwise, we'll call the next number, ना? Please come fast. You don't want or what? Arey, Tariq, you have to.
So all other
Answer,
all
answer,
others are
answer, answer,
requested.
Srinivas. Answer.
This is the first time we are excusing.
पैसा क्या क्या कराता है? सब कुछ कराता है. Come. What's your name, please? तो आपने पहले क्यों नहीं पहना T-shirt?
She never thought she's going to be lucky.
So you accept this, accept.
So she got the cash award of 5,000.
पहले कभी मिला इतना पैसा?
Sir, I don't know Hindi, sir.
You have you ever got money?
Yes, sir.
Enjoy. One more, Tariq, you have to take it out.
Let's see who's the next lucky person.
This is 311. 311, anybody?
Yeah, come fast.
Come. Your name, please?
Dr. Tavish.
From?
RPC.
RPC? Oh, yeah.
फिर नहीं मिलेगा. That will become biased.
Enjoy your day. So we move on to the second round, that is the medical case. And we'll again start with the red team, I think.
So, okay, we'll start with the case. So, I'm Carmen Chan from Hong Kong, so I'm totally unfamiliar with this concept of SFO. So, but still, I will try to do my best for the red team. Look, even the background color is red. And I'm going to present a young lady with progressive scleritis. So to fit with the scheme, I mean, she is a 27-year-old Chinese lady with unremarkable medical history, and she presented with a 4-week history of left eye redness and pain. And this is what she looks like on the slit lamp. So on examination, there were some anterior chamber cells, some vitreous cells, but she also had a supranasal kind of choroiditis or choroidal mass. And this is what it looks like on fundoscopy. So it's whitish, it's ill-defined. So the B scan shows that there's a substantial choroidal mass with mild vitritis. So the blood tests were unremarkable. The ANA, rheumatoid factor, ANCA were negative. Syphilis serology, HIV, IGRO were negative. General blood tests were also normal, but she does have a slightly raised ESR. So MRI of the orbit showed an intraconal orbital mass in the supranasal quadrant suggestive of nodular scleritis, and she also had a mildly enlarged lacrimal glands bilaterally. So she actually had a PET CT as well, which showed a hypermetabolic intraconal mass of the left eye and also bilateral tonsillar uptake. Of the PET CT of the lungs showed multiple pulmonary masses. So at this point, we always we kind of think that this can be an inflammatory disease, so we actually treated her with high-dose oral steroid 1 milligram per kilogram for 2 weeks, plus non-steroidals, because we treated her as non-infectious scleritis. However, there was no response, and in fact, it was getting even worse. So what would be your differential diagnosis at this point? Would it be A, tuberculosis, B, sarcoidosis, C, metastasis, D, lymphoma, and E, something else? But I think in the interest of time, I will tell you what we did next. We did a scleral biopsy. So the scleral biopsy actually showed plasma cells, lymphocytes, and neutrophils. And this immunostaining showed it was a mixed population of B cells with IgG4 constituting about 20% of the IgG4 cells. So the serum IgG4 level was elevated, and also the tonsillar biopsy also showed IgG4 plasma cells as well as the open lung biopsy. So the eventual diagnosis was probable left eye intraocular IgG4 disease. So I will not have time to go through the diagnostic criteria, but I just want to let you know that intraocular IgG4 disease is very rare. She was treated on high-dose intravenous methylprednisolone followed by high-dose oral prednisolone, but despite that, she actually got worse, and her right eye became involved when she was on prednisolone 50 milligrams per day. So she was eventually treated with rituximab, mycophenolate, and tacrolimus with the help of our rheumatologist. And unfortunately, although her left eye became physical with no light perception, her right eye responded well, and she retained normal vision a few years down the line. So thank you very much.
Thank you. Wonderful case. Now it's
how many of people have heard this diagnosis? What diagnosis you made?
IgG4 intraocular disease.
Yeah. So judges, marks 9. All 9. Yes, 9.
Thank you.
so now roll the dice. From 22 to 20 is not much.
It's a very well worked up, very nicely presented.
Now the turn of the team yellow.
Yeah.
Go for your medal.
So thank you, sir. Lots of pressure. So I'll be presenting the secret beneath. So 29-year-old African origin female presented with a diminution of vision in her right eye. Her anterior segment examination was normal. This is her OCT picture showing some subretinal fluid with a PED. She was advised an anti-VEGF agent elsewhere, unfortunately. When she came to know, I did a fundus examination. I could see a choroidal mass approximately 3 millimeters in disc area. There was an adjacent exudative detachment. There was also vitreous inflammation. So this gave me an idea that this could be probably a tubercular lesion or a sarcoidosis lesion. So I did some investigations. FFA and ICG angiography, they showed early hyperfluorescence, which gradually increased in intensity, suggesting the possibility of a choroidal granuloma only. All the blood investigations were, however, normal. When I did a chest X-ray, it revealed a homogeneous opacity with pleural effusion. There was collapse of the middle and the lower lobe of the right lung. Further investigations were further done, like a HRCT, a MRI, and bronchial lavage was also performed. The MRI showed multiple enhancing lesions in both the cerebral as well as cerebral hemispheres, which was suggestive of metastasis. Even in the globe, we could see a plaque-like lesion which was extending up to the optic disc. The mediastinal in the right, hilar lymphadenopathy, on CT angiography that showed lymphadenopathy with central necrosis. There were even multiple hypodense lesions in the cortex of bilateral kidneys and the left lower lobe of the liver and the right adrenal gland. FNAC, which was done, it showed paratrache taken from the lymph node. It showed scattered overlapping clusters of pleomorphic epithelial cells. This was positive for adenocarcinoma. So hence the final diagnosis was a moderately differentiated pulmonary endocarcinoma, that is stage 4, with metastasis to all the organs, and the patient was sent to oncologist for a chemotherapy. So here, where a patient was suggested for anti-VEGF therapy, finally turned out to be a metastatic lesion with a primary in the lung. So choroidal metastasis can be a very rare presenting feature of lung adenocarcinoma. The age of the patient was only 29 years. He was a non-smoker. So this is a very atypical presentation in such a young patient with a unilateral presentation. It's not reported in world literature. So to conclude, in any case of choroidal mass with exudative retinal detachment needs a complete evaluation and a multidisciplinary approach. So the only thing which I could do for this patient, the only fun part, I could give her few more years to spend with her family and her kids, and she was really, very grateful to me. Thank you.
And what happened to the eye?
Sir, the patient didn't come to follow up for me because she was in Africa. Once she started her chemotherapy, she went there.
Okay. Very nice, very nice. How many marks, Nitin, you want to give? 8. I 8 से ऊपर नीचे ही नहीं होता सब everything is stuck to 8.
Figure of 8.
8. Dice 3. Yellow. Yeah, yellow is leading, yeah. So now we have the blue telling us about the medical case.
Yes, sir.
Prasanna.
Thank you for the opportunity. Diagnosing early glaucomatous damage in a homonymous semionopic patient with spectralis domain OCT. So if in clinical practice, if there is a glaucoma or a neurological disc pallor, that itself is very difficult to diagnose. To add on, if you are going to get both in one patient, especially when they are going to coexist in each other, that is going to cause a lot of headache. In this case, we diagnosed how early glaucomatous structural damage in a pre-existing non-glaucomatous neurological damage disc with a novel BMO MRW tool. So this, my dear friends, is revolutionizing the way we understand glaucomatous damage in the structural platform called the Brooks membrane opening the red dot, and then the Brooks membrane opening minimum rim width, which is actually the distance between the internal limiting membrane and this red dot called the BMO, and this is changing the whole spectrum of glaucoma. Previously it was the horizontal rim width that we used to see that this is the distance, but now the technology is such that the minimum rim width or BMO MRW. So why it is superior compared to its other thing is, it also even tracks an eye movement, and early progression can actually make even 1 to 2 micrometers can be picked up with this particular sensor that is actually available. And then it gives you not only the foveal center, also the center of the disc, and then you plot a GPS axis called the fovea BMO axis, and then you take over. So let's move to the case. A 73-year-old male came with a 30-year-old back orbital infarct, hemianopia, and mild diminution of vision. Everything appears to be normal, but at the same time, a phasing shows IOP only up to 20/21 with a mild pallor and a 0.7 cup in both eyes. And if you see the visual fields, there is hemianopia 10-2, 24-2, OCT, and the BMO MRW scans were done. And between 3 months, as you can see in this, there is a progression in RNFL and the GCL, because it gives you even 1 to 2 micrometers progression in both eyes. And you can see this is March and this is December. Between 3 months, there is progression documented. So the rationale for diagnosis, mild diminution of vision in the remaining half of the field, occipital lobe infarct, does not cause glaucomatous cupping, diurnal variation of IOP up to 21, and there is a breaching of ISNT rule, and the documentation of the BMO MRW constriction and the inception of the superior arcuate scotoma, and we started the patient on Dorzox, and there was, if not mild improvement from March 2022 to 2023, and he's still holding good up till now. And these are the results that you can see, and we started the patient on NTG. We are Team Blue, Team Dorzox. If you saw our SFO flyer, we were named Team Dorzox for a reason. The patient was started on dorzolamide 2% eye drops. He's up to 5 years now, and the disease has stabilized with no progression. This patient would have gone for blindness if it was not picked early and if the medication was not started early. So we saved the patient, and he's happy patient, and he's doing well. Thank you once again for the opportunity.
So now judges turn. 9, 9.
10.
Okay. Roll the dice. 1. 26. Still the fight is very close. 20, 28, 26. Any team can win.
So green team has to work hard.
And after this, please select, all of you please select your member who is going to take up the quiz. All teams to select the member to take up the quiz.
May I start? Very good afternoon to all of you. Just I request all of you, please sit your chair and go back to, just switch on the time machine, go back to 4 years back. And just imagine the month of May 2021, the massacre by the pan-India. And this scenario, just imagine the patient come, and my title of presentation, in the surge of pandemic, all red inflamed eyes are not by black bugs. I have no financial interest. The lady 45-year female presented with a sudden onset of pain and swelling the both eye with the dimness of vision with the mild fever for 15 days on the month of May 2021. And she's a known case of uncontrolled diabetes with under insulin and oral medications. And a VCBO was right at 6/12, left eye 1/60. And this clinical presentation Diagnosed elsewhere is a preoptal cellulitis left eye, and oculoplasty consultant started IV medication, and the COVID RT-PCR was negative. The clinically generalized toxic look is the parallel swelling. And on discharge from the oculoplasty consultation, he was referred to us for the cornea clinic for OU generalized swelling with the peripheral infiltration on the both eye with conjunctival epithelial defect. And she having this panorama of the presentation. We have done the scraping throughout the infection and sent the collagen vascular workup, including the CVC, CRP, ESR, RA, and thyroid function test along with ANCA, and again repeat the RT-PCR, which came negative. And we have started the the medication along with the gatifloxin eye drop, homatropin, CMC with low dose of loteprol with close monitoring, and the coverage of topical, antifungal, and oral itraconazole by the ENT consultation. But in spite of the aggressive medication, she was progressing, deteriorating. Meanwhile, we pushed the more confusion when we've done the MRI. There is a must-like things are there and suspected mucor. We are really in dilemma. Again, the ENT consultation done and the sent to the physician for the DM. But really, they're confusing both of them as maybe probably you are dealing with the mucormycosis. But when the inflammation increased, the eye was deteriorating, and repeat scraping, everything negative. Then by that time, the report come, the CRP and the RA was positive. Then we started the topical medication, low dose of loteprol. We sent the physician for the oral medication clearance, but they said there is very confusing. We can't start the thing. Then I start the methotrexate orally with the injection triamcinolone in spite of the oral topical vizolone. Restart the loteprol eye drop with close monitoring and moderate symptomatic improvement. Then we found the literature search, and then probably convinced the physician and the ENT, and we have started the very low dose 0.5 milligram per kg and half dose of the oral prednisolone, and the patient dramatically improved within 1 week, and the BC was 6/9. So due to the surge of not only pandemic, even now also, if the sometime patient come with inflamed eye with the mucor, and suspect mucor, then oral steroid given sometimes confusing these things. So specific characteristic of the inflammation of the puke and the through workup of the collagen vascular disease is indeed, and we found that the literature along with our cases, the RA could be the first presentation in case of unknown undiagnosed rheumatoid arthritis patient. Bilateral RA could be the presence, and bilateral your vasculitis, bilateral scleritis, bilateral orbital cellulitis could be the first presentation of the known case of RA patient, and that's the clinical part of this presentation. And now come back to the present scenario. Thank you very much.
So ultimately it was not mucor.
The patient is improved,
Okay,
and
judges'
definitely
marks.
the take.
8.
Thank you.
Now the roll of the dice. 3.
So it's, I think yellow and blue team are ahead. Yellow.
But now the prizes for the audience, and now अगली बार यार बीच में क्यों डाल?
So all of you who are wearing white t-shirts, they should just see their
Please
number.
remember your number. If you do not remember, we are going to not call you on the
Yeah, yeah.
stage. So please do remember your number.
293. Please
Come fast.
One more.
So now the price is increased to 7,500.
बहुत amount है 7,000. One more. Please come. Hi, congratulations. You are from which place?
I'm Pavitra from Mahatma Hospital, Trichy, sir.
Good.
Sorry, going to give it to a mentor. You enjoy.
So next, you take out the next
One more,
from
one
standing
more.
here only. So again, please remember your t-shirt number.
It's 318.
Is 318 here?
318 has to be here.
Come fast.
Disqualify हो जाओगे आप. You have to wear it. You will get disqualified.
कर दे?
हाँ एक तो कर देना चाहिए. We
आधा
have
कर
to-
देते हैं, आधे पैसे निकाल लेते हैं.
देखो वो देखो उल्टा फुल्टा सब पहन रहे हो सब पैसे के लिए सब कुछ पहनेगा एक फोटो खींचो इसका एक फोटो खींच इसका देखो
ऐसे ही रहते हैं, ऐसे ही ले ले, चलो ले.
give it to him नहीं you still want to give it to him इसने पहना तो नहीं okay चल congratulations चल okay move to the next round.
So now the next round, let's see how updated you are with the latest ophthalmology. So first team to go is the red team.
Come this
Please,
side.
come on this
The
side.
entire team, please go that side. We'll start the quiz. Yeah. Yes, you all can consult each other.
No, she will be the ultimate, and you can prompt her.
So
can
as you
take help.
move up, I'll read out the rules of the game. So this is the rapid fire quiz round. Each team has 2 minutes to answer a maximum of...
First, be attentive, please. Don't miss on.
Yeah, sure.
Okay. Are you ready? Yeah. So each team has 2 minutes to answer a maximum of 10 questions. You have 10 questions. Try to answer as fast as you can. All the team members can participate. There is no negative marking. You either answer the questions or you can say pass if you don't know the answer. It is not possible to go back to a question later. So try to answer quickly so that you can answer maximum number of questions in those 2 minutes. Think wisely and answer quickly. And last of all, the quiz master's decision
You
is
can,
final.
instead of passing, you can have a wild guess. I mean, you don't have to pass, just say anything.
Yeah, there's
Just
no
pass,
negative marking.
Don't waste your time.
Yeah.
Don't waste your time.
We don't
And the other members can prompt from the behind, but one person has to click the button.
So one person would be answering. Dr. Ellie Pradhan would be answering, I suppose.
Yeah.
So with that,
Nothing, yeah.
I request Dr. Ikeda to keep score. And with that, we start the timer. And I go on to the first question. Are you ready?
Yes.
All right. Conjunctival melanoma arising from which of the following source has the highest rate of metastasis? Arising from PAM, arising from pre-existing conjunctival nevi, arising de novo, risk of metastasis not related to the origin.
A, arising from PAM.
That's the wrong answer. Next question. Autosomal recessive form of sclerocornea is caused due to a mutation in the KERA gene that encodes for keratoglycan proteoglycan, lumican proteoglycan, dermatan sulfate, or keratin.
A.
That's the correct answer. The third question, which is the most common collagen vascular disease associated with episcleritis? Rheumatoid arthritis, SLE, relapsing polychondritis, or ankylosing spondylitis?
A, rheumatoid arthritis.
That's correct. Which formula is used for calculating the power of ICL? The van der Heijst formula, Barrett-Fakik IOL formula, Fingold and Olsen formula, or the Mascot formula?
B, Barrett-Fakik IOL formula.
Is the Fingold and Olsen formula. Who designed the first toric IOL to correct corneal astigmatism? Robert Koch, Henry Clayman, Kai Ahau, or Kimiya Shimizu?
Pass.
So it's Kimiya Shimizu. Which of the following theories is not related to accommodation of crystalline lens? The Helmholtz theory, the Shacker theory, the
A, Helmholtz theory.
No, that's wrong. It's the Muller's theory. This fundus photo demonstrates massive subretinal exudate at the macula of a 6-year-old boy.
Coast disease.
Absolutely correct. Which of the following is used for the treatment of liganous conjunctivitis? Topical heparin, topical antibiotics, topical mitomycin, topical prostaglandin analogues. So with that,
Time is
see,
over.
time is up.
Topical mitomycin.
Time is up.
No, it's topical heparin.
How many
So I
correct
request Dr. Ikeda, please tell us the score.
So the team red has scored 3 out of 10. A big round of applause, please. They were little tough questions.
Roll the dice. 1.
So you have finished your team red. So next team is team yellow.
So
Team
don't have
yellow.
be disappointed. There are assured prizes for all the participating team.
Yes, yellow, please come. Asif.
Team yellow, are we ready? Who's going to take the
No,
lead?
They don't know. Can we start? Yeah.
All right. Dr. Tinku, can we please have the timer set to 2?
Okay, so I'm starting.
Which is the most common complication associated with Boston type 1 keratopathy?
RPM D.
Yeah, DRPM is the right answer. For pediatric vision testing, all of the following tests rely on preferential looking except tele-acuity cards, Lea paddles, Cardiff cards, or Boeck Candy test.
Boeck Candy test.
Correct. Cherry red macula is not seen in CRAO.
Krabbe's disease D.
Sorry?
Krabbe's disease D.
Yeah, that's the correct answer, Krabbe's disease. All of the following are named after the Australian ophthalmologist Carl Ferdinand von Alt except Arl's surgery, Arl's enucleation technique, Arl's syndrome, or Arl's circle.
C. Arl syndrome.
That's the wrong answer. The correct answer is Arl's circle. Which of the following drugs have been associated with iris cyst formation? Phenylephrine, latanoprost, dorzolamide, or rho kinase inhibitors?
Phenylephrine A.
That's the wrong answer, latanoprost. Which of the following types of uveitis would not be expected to present with the appearance as shown? A.
B27 associated iritis.
Yes,
A.
that's the correct answer. What is Chandler's classification used for? Pigmentary glaucoma, eye syndrome, orbital infections, or idiopathic orbital inflammatory disease?
Orbital infection C.
That's the right answer. The shortest extraocular muscle is superior oblique, inferior oblique, superior.
B. Inferior oblique.
That's the right answer. Which of the following is the most likely risk factor for uveitis in patients with JIA? Arthritis onset after 2 years, more than 4 joints, female gender, or absence of ANA positivity?
C. Female gender.
That's the right answer. And we have a song for you since you have reached towards the end. Can we have them identify the song and singer? Or either one of them. It's an eye-related song.
Ed Sheeran.
Something to do with eyes?
Ed Sheeran.
Okay. So this is Eyes on You by Jay Sean. A very popular number back when we were in medical college.
ये तो non-ophthalmic में हो गए.
Last
But-
fun question. Eye-related song.
Eye-related song. So how much is the marks?
So, Team Yellow, congratulations. You have a very high score of 7. Give them a big round of applause.
7 means 70 marks. 7.
7.
Oh.
Take this ladder as well.
Where are you? Tasif, क्या करते हैं? What do you do? Very nice, very nice. Best of luck. कौन करेगा? कौशिक नहीं ये भी 10 मिनट लेने वाला है. Yes.
Are you
Tinku,
ready?
Yeah.
Yeah. Can we start?
Yes, I'm starting the timer. Start.
Okay. Which one of the following conditions has been associated
Aniridia,
with...
B.
Correct. Which football player was a qualified ophthalmologist? Socrates, Zico, Falcao, or Garrincha?
Falcao.
It's Socrates. Which scientist's eyes were removed during an autopsy and are still stored in a locker in New York? Isaac
Einstein.
Newton. Einstein, that's correct. Which of the following statements is most likely to be correct for a patient presenting with a symptomatic retinal dialysis? Other signs of blunt ocular trauma are usually present. The duration of retinal detachment is...
A.
No, that's not true. The macula is most likely detached. What does 23 gauge measurement stand for? You can see those notations.
0.455.
It's 0.574 millimeters. Yes, that was wrong. What is the percentage of patients with ankylosing spondylitis who possess the HLA-B27 gene?
More than 75%.
That's correct. Early findings in VKH does not include tinnitus.
Vitiligo.
Vitiligo, that's correct, it's late. Imaging study best to evaluate a patient with homonymous hemianopia is MRI with contrast, MRI without contrast, CT with contrast, or CT without contrast.
B.
It's A, MRI with contrast. How much toric IOL rotation can occur before the IOL stops
30
compensating?
degree.
What did you say?
30 B.
30B. That's correct. And for you also, since you've answered all the questions nicely, can you put on the song? So we have a song which is related. It has...
close. 'Cause everywhere I look, I still see you. And time is moving so slow.
Yeah.
And I don't know what else that
Okay, time up. So this was Ed Sheeran, Eyes Closed. Okay, so Dr. Kedar,
Score,
tell us
score,
the
score.
Kedar.
So team has scored 5 out of 10. Big round of applause.
And roll the dice.
Roll the dice, dice. Wait, wait.
5.
Total 36. So, congratulations. ये कौशिक की प्रॉपर्टी पता क्या है? Before the question finishes, he answers. Before the question finishes.
But still, Team Blue is
Yeah,
leading
green,
at science
green.
part.
Who is going to answer? You will answer? Yeah, please stand. All of you can prompt.
Okay.
Yeah. Ikeda, you can
Are
start.
we ready?
Yeah, yeah.
Can we have the timer, please?
Okay, timer start.
Identify this legend. Yes, Gulstrand is correct. Most ocular and orbital ultrasound is performed in the range of. Please be loud, I can't hear you. A, B, C or D? That's the wrong answer. Identify this condition.
Quotes, they said.
That's the wrong answer. What is aflibercept, ILIA? A fusion protein. A fusion protein. I request you to be loud. What is the only extraocular muscle typically supplied by
D.
D? Yeah, that's the correct answer. With a full thickness macular hole in one eye, the chances of macular hole in the other eye?
25.
That's the
Speak
wrong
loud, yeah.
answer. What eyelid malignancy is prone to invade locally by spreading along the nerves? The sebaceous cell carcinoma? Please repeat. C, squamous cell carcinoma. That's correct. Yeah, that's correct. Which one will produce this field defect? A pituitary tumor, a occipital lobe infarct? Can you please repeat?
Speak in the mic.
In the mic. Final answer? A is right. The suspensory ligament of the globe is...
ligament, A.
That's the wrong answer. It's the Lockwood's ligament. And again, we have an eye-related song for you. Identify either the song or the singer. A very popular song. A lot of people have done versions of it, covers of it. Time is up. This is Can't Take My Eyes
None
Off
of the
You.
12 people could identify the song. Neither the judges.
Okay, let's see if anybody in the audience can identify this song.
No, I've given
किसी
the
को पता
answer
है?
now. Okay.
देखो 150 लोगों को पता नहीं है.
Yes, she's saying something.
Good.
She gave the correct answer.
She gave the correct answer. You will get the special prize after end of the contest.
Yes, marks.
This is Frankie Valli, the lead singer of Four Seasons, but this song has been redone by a lot of people. The original is by them.
Marks.
Oh yeah, marks. Sorry.
Marks, please.
Just give me a moment. 5. So they get 5 marks out of 10. Big round of applause.
Roll the dice. 8.
So
Now we'll have lucky draw for the audience.
So the lucky draw for the audience is this time has been increased to 10,000 rupees. So please remember your jersey number and run fast. If you do not remember, you are not going to get it.
357. 10,000 rupees.
357, gone. Leave it. If it doesn't remember, it's gone.
357. 370. 370. He's so happy.
So now we,
One more. One more. 139. 139. Nobody.
so judges meanwhile think of some lifestyle questions. As they ask in Miss India contest or something, you have got to ask the
104. People are taking the decision going away. Triple one. Triple one. 111. Madam, come fast. You're lucky always or आज ही lucky हुआ है?
नहीं सर बहुत बार
ये दे जाओ, ये वापस ले लो। Okay, thank you, thank you. So we'll
now,
have
now the team red comes on the stage.
Yeah, team red, can you please come here? Or Ragini. This is a a lifestyle question.
Nitin,
So,
each judge has to ask one, and Nitin will ask two questions. So put over some question, nothing to do with the science, anything about the life and
Lifestyle,
philosophy of life, anything you want to ask.
yeah,
1 minute, 1 minute.
Can I think for 10 seconds before
Yeah. You can think for 30 seconds and answer in 30 seconds. That's okay. Total time is 1 minute. Yeah. After the completion of the question.
Yeah. Look, how do you maintain you've got a family, you've got your professional, you've got your academic life, and you also need time for yourself. How do you maintain that work life and your self balance on a day-to-day basis?
So that's possible because I'm a woman. Only a woman can multitask. She's a mother, she's a nurturer, she's a working woman, and she has the ability to do administration. So every woman here gets up in the morning, looks after her house, runs to work, looks after her family, comes back home and still finds time to go to the gym or to the beauty parlor, sir. It's being a woman, sir, that makes it possible.
Okay. So now, judges, can you give the marks for this?
I don't disagree that there is men and women. So a man makes a woman complete.
10.
Ragini, all 10.
So now the game is not over. Look at the dice. Any team can go up and down. 3.
13.
So where the team reaches now?
37.
Good. So now the team yellow
team.
come on this stage.
Wait, don't ask same question to all the women, yeah? Pranita.
So you put up a question.
Yes, madam.
Nitin, you ready for the second question as well?
I'll come later. Lalita.
With your busy schedule.
Volume, put on the mic.
Yeah. With your busy schedule, how do you just enjoy your entertainment? What are the entertainments that you during your happy time to reduce stress in your life? What is the entertainment?
Yeah,
you
so
are
I have a
just
3.5-year-old daughter. All my entertainment happens with her. I had a conference, I had an OPD, and in the morning my daughter had the first day to school, and I had all the fun with her in the morning, did the OPD and came here to the SFO, thanks to sir. So all my fun and entertainment is with my daughter.
Okay, good.
So now marks. All of you can think about 9. 1. So this goes to 53, still leading. Yeah, team blue.
Yes, sir. Sir, you ask.
Okay. So there's a lot of young people in the audience, and you, sir, look very young.
Thank you.
My question is, at what age should children be allowed to use social media and why?
At what age should children be allowed to?
Use social media. Social media.
अभी नहीं timer नहीं, हाँ?
At what age social media have children?
So honestly speaking, there should not be any age of social media because we as parents have spoiled our kids. The day they are born, we can't give them attention. So what we give them? Mobile. So they are busy right from the day they are born with the social media. Even if we try to regulate and stop them, we can't because even the schools are promoting everything on social media. Everything is now on social media. We can't deny that technology from our kids. Yes, but we have to tell our kids how to select the appropriate knowledge from social media. We should not get hooked to it. We have to advise our kids. Social media has both the plus and the minus. We should encourage our kids only to use the plus. And plus, we as an ophthalmologist, we should tell our kids how to relax your eyes, how to relax your accommodation, so that they can talk to their friends that my dad, मेरे पापा, मेरी मम्मी डॉक्टर है, आँख की डॉक्टर है, सोशल मीडिया पे कैसे काम करना है ये ध्यान रखो, अपनी आँख खराब मत करो, वो ज़्यादा इंपॉर्टेंट है. गिव आइज 20-20-20 रूल सिखाओ. जब बच्चे सिखाएंगे अपने दोस्तों को तो दे विल बी वेरी प्राउड ऑफ इट. थैंक यू.
So I think just start of the conference, we had a press conference which has been widely covered not only in India but across the world. Whether it's Malayali, Kerala, Ahmedabad, so more than 100 coverage has been already on all the TVs and all the international. You can go and look into it. The real effect on the eyes of the masses.
10, 9.
9. Roll the dice.
Wow.
6.
What? Yeah,
So
you
they
have
can
10.
jump.
You can,
3.
9.
Oh.
Oh! Oh! Amit Porwal, what have you done? What have you done?
So the game can change anytime.
Yeah. Yes, question to her. Yeah. Ask one question.
Look, very often as a family, you must sit together and decide now, we are going to go on a holiday somewhere. You do go on holidays. And your kids have got their side of it, your partner has got his side of it. And how do you come to a consensus on things for fun in your family?
Sir, I believe there is nothing like balancing. Anything worth balancing unbalances your life. Like everything is hard. Marriage is hard, divorce is hard, positivity is hard, getting up is hard, carrying on is hard, giving up is hard. So you have to manage. It's like juggling between the opposites and making the ends meet. So, I would choose the harder, but I would try to make it easier for the people around me. And I believe that we have to bloom wherever we are planted.
Okay, thank you. So now, judges turn to mark it. Yeah. 8, 9, 9. 9. Roll the dice. 2. So now, marks are on the screen which you can see. One is only science and another is science and fun. एक मिनट यार. So in the bottom, there are marks for the SFO, that means science and fun both. And in between, you can see 30, 33, 34, and 30. This is for the science. The first prize, science and fun both goes to the team blue with the 54.
Team blue. Abhi we'll have one lucky prize for the audience. After that, we'll do that.
Okay. So team blue can come. पहले prizes कर लेना. Prizes करके फिर निकालेंगे.
Okay.
Let's have the team blue here on this stage.
Team blue, you should, only Amit Porwal, you can come, let them stay. You have tilted everything here. What have you done? You see, you have taken this SFO, you have taken the science also.
Come fast, yeah.
All of you come.
Hold it.
Nitin.
चलो आजा फटाफट.
Let the judges come.
Sir, ma'am, I'll sit down.
कोई बात नहीं. आजा.
बैठे तुम ज़्यादा अच्छी फोटो भी है. तुम भी जाओ. चलो. Come, Nitin, in the center. Madam.
अरे वो डिस्प्ले रखो यार. स्कोर कार्ड रहने दो वहाँ पे.
Yeah.
चलो 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 ठीक है. So the team blue was highest in the science also, but the one team cannot have two prizes. So the science prize goes to the team yellow, because team yellow and blue, actually there was a difference of only 1 mark in the science as well as in the luck. So that is where the luck plays the part. So now we invite Prafulla Marana and team yellow on this stage for the second prize of the science. And the SFO second prize goes to team green after this, and the last will be team red. So now the second support team is team green. Please come on this stage.
Next.
Team green, 40,000. नहीं आपको उसका मिलेगा. No, SFO they got 39, you got 37. You'll get the science prize. So now team red for the runner-up prize of the science.
देखो कई बार क्या होता है 10 मिलने के बाद ही
Okay. So now we'll give one lucky draw, final, and one that girl who selected the song, come on this stage. One last lucky draw, come on this stage. Tell what's your name? So you will be getting 10,000 rupees for guessing it correctly.
Thank you, sir.
Come on this side. Lalit, pakad ise. Come on. Yeah. Nobody could guess anything about that song. So luck can come from any corner. So now last lucky prize. Let's see, we have got only one packet left.
This is 80.
Oh! पहली बार में आ गया बंदा है. Come fast. लो. At the end, patience pays. Oh! I think in the future he will forget about ophthalmology, will continue doing this only. Yeah. With this, we come to the close of this session. Thank you all. See you next time somewhere else. Group photograph. अच्छा चलो.
Vinder, with the head.
Yeah.
अरे पिक्चर ले. एजी एक पिक्चर ले. अरे यार इतना यार ड्रामे चाहिए इनको यार.
हाँ ले फटाफट यार. Good, thank you.
Okay, I better run to
और चलो अपने चारों के लिए नहीं है. Okay, bye. आजा ललित अपने चारों के लिए.